All right, thank you very much, everybody. Warm welcome to those attending and also to our viewers watching live on the Council's YouTube channel, Hillingdon, London. This is a meeting of the External Services Select Committee. My name is Councillor John Riley and I'm the chairman of this meeting. A key role of this committee is to monitor the performance of local public services within its remit and to hold in-depth reviews on topics of resident interest. We engage with a wide range of external witnesses in our activity, which can include community groups, residents and subject matter experts. Where we identify areas for change or improvement, we make recommendations to the decision-making cabinet. Details of the business to be considered today is shown on the agenda, copies of which are available in the room and also accessible on YouTube underneath the broadcast. For those present in the room and intended to speak, please note that you will be filmed and any statements you make will be recorded and made public. For those in the public gallery, you won't be on camera. A reminder to councillors, officers and those speaking today that you should turn the microphone button on when speaking, and this will ensure that you can be heard in the room by those watching online. What we'll do, as we normally do on this committee, is when people speak for the first time, they should introduce themselves, and then we'll go from there. All right. Welcome, everybody. So, first of all, apologies for absence and to report any substitutes.
Chairman, there are no apologies for absence.
Excellent. Thank you very much. Declarations of interest in matters coming before the committee? Usual, but nothing specific. Oh, any? No? Okay. Just to confirm that everything in Part 1 will be considered in public and any items marked Part 2 will be considered in private, but I don't think we've got any Part 2 matters so far. Item 4, minutes of the previous meeting, which was the 5th of September, and you have them before you in your blue documents. We had the Safer Hillingdon Partnership Performance Monitoring, and you'll remember what we went through as far as that was concerned, all set out in the minutes. We had Dan Kennedy and Superintendent Candola, and that's right, PC Hull, who was here, and we did say that we'd ask her back, didn't we? Have we arranged that? Yeah. Okay, so she's coming later in November because she was terribly, what she had to say was terribly important, and we need to talk to her about that. So, has anybody got any issues raised out of the minutes of the last meeting? Can they be agreed? Excellent. All right, now we've got item 5, which is the Mount Vernon Cancer Centre update, and then item 6, the dental health services, but I think we're going to have to change those around in terms of order. We're going to do the dental health services first because the people from the Mount Vernon Cancer Centre review are stuck somewhere on the M25 or something like that. So, dental services. This came about as a result of some issues and queries that were raised by members last time, and you will see in the report at item 6 how we looked at that, how it was that the Social Services, Housing and Public Health Policy Overview Committee previously, 2015, presented a report to Cabinet on children's oral health and other aspects. So it caused us to have a look into this, and thank you very much for everybody from the dental services for coming. It's something that we really ought to look at more often, I think. But we're very grateful for you coming along. So if you'd like to start with your presentations as far as dental services is concerned, we have a number of different questions. Okay. Let me see if I've got them. Yeah. Okay. So, all right. We'll start with the Whittington Health Trust, I think, first, if we can.
Thank you very much. Thank you for the invitation this evening. By way of introduction, my name is Dr. Andrew Reid. I'm a consultant and clinical director for Whittington Health and NHS Trust. I'm here to talk about the community dental service, which we provide in Hillingdon. And with me tonight is Aisha Masood, who is our lead for oral health promotion in the Borough of Hillingdon. So I plan to just do a short presentation, some of which may answer some of the points raised previously, but we're happy to take any points and clarification and questions after I've spoken. This is the clicker, isn't it?
Turn it on at the side.
Thank you. So who are we? Whittington Health NHS Trust is an integrated care organisation combining community services that we provide across the boroughs in North London, along with acute services from our hospital site, which is at the Whittington Hospital in Archway, North London. And as a trust, we employ approximately 4,300 staff. The Whittington Health Community Dental Service we provide from approximately 20 sites across 10 London boroughs in North Central and North West London and employ over 130 staff. The Hillingdon Community Dental Service transferred to Whittington Health in April 2019, so about 6 months ago. What do we do as a community dental service? I think if you were to summarise it in one sentence, it would be to provide treatment to patients with complex needs who are unable to receive treatment in a general dental or high street dental practice. The services we provide include paediatric dentistry, that's approximately 70% of our workload, adult special care dentistry, which is services to patients with complex disabilities, so for example people with severe learning difficulties, frail older people, people with medical issues that require additional provision, and so on. We also provide services under sedation, and in some of our boroughs we provide general anaesthetic services too. We provide domiciliary services on demand, and one of the most important parts of our work is our community oral health promotion and preventive programs. And we'll talk about that a little bit later. And finally, we carry out surveys of dental health of the local population, principally children and young children. Our clinical services are provided in Hillingdon at a clinic in Redford Way, Uxbridge. And I need to tell you a little bit more about this because I think an issue was raised about the service there. So these are new premises that we fitted out earlier this year, and this clinic was operational from approximately June the 17th this year. However, because the clinic is on a first floor, we had planned and designed lift construction to be ready for operation of services when it opened on June the 17th. And the lift construction was delayed. And so for those patients that, and a significant number of our patients who do require lift access to be able to access dental services, then we wrote to all those patients explaining the delay to the lift construction and indicating if they had urgent needs or even if they had any concerns and wanted to see a dentist before the lift was completed, that we could see those patients at clinics in neighbouring boroughs, the nearest being in Harrow and Ealing, and some in Hounslow. And we may pick up that issue a little bit later on. So in terms of where we're successful, where we believe we're successful, we provide what we believe are high-quality, community-based specialist dental services for children and adults with complex needs, and we think we provide a responsive and effective clinical service to those patients. We are a model provider of community preventive and oral health promotion programs, which is recognised by national bodies such as NICE and Public Health England. And I think the third strand of our success is that wherever we've worked, we've found that the best way to achieve the best services for local people is to work in partnership with, whether it be commissioners. Our Commissioner of Dental Services is NHS England. We work very closely with Public Health England, so our consultant in dental public health, who you may be aware of, is Claire Robertson, who we work closely with. And also we work closely with local authorities, because local authorities have the statutory duty to commission services or to commission oral health promotion and public health services to address priorities in terms of oral health need. But we do have challenges. In April 2017, NHS England in London changed the contracts of community dental services so that instead of children being able to be referred from high street dental practices to direct to hospital, all of those patients, paediatric patients, were referred to community dental services. So we have very high volumes of demand, which I'll talk about in a moment, and clearly there is a limit to capacity to deliver care to all that demand. So we have people waiting for treatment. The second area that is a challenge is the oral health care of older people, and principally those who are the most vulnerable and dependent, and those often that we find are the most in need are those who are resident in care homes and nursing homes. And finally, the third challenge is around the commissioning of local oral health promotion and prevention programs, where there is certainly an issue of funding across London, which, although we're beginning to address some of those challenges in oral health promotion, there is still a significant need there for commissioning and funding of local oral health promotion programs. That one. Just to tell you a little bit about dental health in Hillingdon, and principally around oral health for children. 5-year-olds, and we carry out studies of 5-year-olds tooth decay in all the boroughs in London under a national epidemiology programme. The percentage of 5-year-olds experiencing tooth decay in Hillingdon is well above the national average and above the average for London. And perhaps more concerning is that we're now finding that the highest decay rate in London amongst 3-year-olds is actually in Hillingdon. Tooth decay in children is the single biggest cause of non-emergency admissions of children to hospital, and that's principally to have treatment under general anaesthesia. Usually to have teeth extracted, but also to have teeth restored sometimes. There are significant inequalities in dental health, and that is strongly associated with social deprivation. And poor oral health impacts profoundly on a child's development, and there is significant evidence to show that. So it's an important public health issue for Hillingdon and across London. People are often curious as to where they lie in relation to other boroughs. Hillingdon is, I guess, is in the top 5, or the worst 5, depending on how you look at it. I would say, though, that really these surveys are carried out every 2 years?
2 years.
Every 2 years. That really, this year it could be Harrow, next year it could be Hillingdon, 4 years' time it could be another borough, but they're usually within that top half a dozen. Certainly, because we provide the services in Harrow, Brent, and Hillingdon, we're also very, very aware that it's not a problem that's just in Hillingdon. We've got an issue in northwest London as a whole. The other issue that I said was a concern was around the oral health care of older people. There has been a lot of focus on children's oral health in London over the last 5 to 10 years, but we have significant evidence, and we've carried out studies ourselves about the impact of dental disease on older people, principally those who are in nursing homes and care homes. There is a significant amount of guidance that's available through Public Health England and NICE, which is the National Institute for Clinical and Health Excellence, which shows that this is a population in need not just of good dental care, but preventive care also. And then more recently, in June 2019, so very recently, the CQC itself has written a report which has been widely received in the media around the need to improve the oral care of residents in care homes. So how do we get to a position where we prevent poor oral health? What works, what doesn't work? From our perspective, the most important thing is to take note of the evidence of what works. And it's very clear that the things that work on a community basis are those that deliver appropriate levels of fluoride to children, whether it be through supervised toothbrushing schemes in early years settings or fluoride varnish schemes in early years settings. Those stand as having the highest evidence base for impact on dental disease in young children. At present, we're not doing either of those. We're not commissioned to do either of those programs in Hillingdon. We do provide them in other boroughs in North London. We are carrying out a significant amount of work with what I would say is a limited resource in Hillingdon, which is around training staff in early years settings, providing toothbrushes and toothpaste packs through the health visitor distribution system, and through other aspects of multi-component community oral health promotion, and we can talk about that a little bit later in more detail. And just to give you some examples of the kind of work we're doing across London, we work across a number of boroughs, and as I said, we're carrying out fluoride varnish programs in a number of boroughs and supervised toothbrushing programs in many other sites also. So TTT is train the trainer model, and MEC is making every contact count. B4L means brushing for life packs. That's handing out toothpaste packs to through health visitors in early years settings. So we are undertaking quite a bit of work in Hillingdon as it stands, but there is clearly a need to do more, and certainly to commission the type of programs that are being commissioned elsewhere in London and across the UK that are seen as being very effective. So I'm going to leave it there for now and invite any questions or points of clarification. Happy to take any questions.
All right, I think as we've got other dental experts here as well, rather than ask for presentations from them, because I know already I can feel the bristling going on of my members to ask questions. So if questions relate to other people, then pitch in, because really the first thing for me is looking at that graph. What are Bexley doing that we're not, or that isn't happening here, and why are we apparently in Hillingdon quite so bad?
I don't think it's an easy question to answer. I think that I don't know what Bexley is like. I haven't been to Bexley. In terms of its demographics, its inequalities, all I know is that in many parts of North London, not just Hillingdon, there is a significant dental decay problem in young children. And whatever the cause, we have to look at the best evidence for trying to reduce the impact and prevent dental disease in young children. At the moment, a lot of the dental activity is focused what we call downstream. It's looking at the effects of the disease and trying to treat the effects of the disease, and that's proven to have failed because so many children, increasing numbers of children, are going to hospital to have teeth out. So the focus should be on upstream activities. I don't know whether they're doing that in Bexley or not, but I think we just have to work with the situation we have in Hillingdon.
Well, I think we've always looked upon Bexley and Bromley as being very similar boroughs to ours, and I mean, the obvious point is, why are we not looking at what they're doing and seeing what the differences are? Because again, they're certainly their socio-economic splits are not dissimilar to ours. So is work anticipated to be done to look at the good boroughs and say, well, what are they doing that we're not, or what's happening there that's not happening here?
Yes, to some extent. I mean, I don't know whether you want to come in, Aisha, in a moment in relation to Bexley and similar boroughs, but what I would say is that in boroughs like Camden and Islington, probably 10 years ago, we had very high levels of tooth decay in 5-year-olds, and there was a significant investment in local authority commissioned oral health promotion programs, principally at that time around fluoride varnish schemes, but more recently supervised toothbrushing schemes. And now we're seeing the decay levels in those boroughs coming down. Whilst I'd be always a little bit cautious about interpreting cause and effect, I feel we're doing the right things there because there is an evidence base for it. So my feeling would be is that perhaps some of the success in other boroughs, as evidenced by their low rates of decay, might be to do with those public health programs.
All right, Councillor Riley.
I guess I just want to reiterate the point Councillor Riley made, which is I think it's useful to understand why are we so low, why is oral health so bad, particularly in Hillingdon. And if I'm not mistaken, I think you said the two methods, the supervised tooth brushing and the fluoride varnish scheme, the two that have the highest impact aren't being done in Hillingdon. Why?
It hasn't been commissioned.
Why?
Well, we're a provider, so we are commissioned by NHS England to provide a community dental service, but the duty to commission public health services, which include oral health promotion, lies with the local authority.
Councillor Riley.
I suspect someone's going to get back to that bit, so I'm going to quickly ask a separate bit. So, you know, when we talk about early prevention, I don't know if the dental sort of health sector is different to the wider health sector, but presumably by the time someone's gone to have a child has gone to have their teeth pulled, or in A&E, that's quite far along the process in which there could have been interventions, not just in a proactive way of brushing, but when things were going wrong, they could have gone to see a dentist. And presumably the reason it's so high is because they're not. I'm curious as to why parents and carers and children aren't coming in when early symptoms are showing up, because from what I'm reading, I mean, under 18-year-olds can get it for free, so cost shouldn't be an issue unless there's a perception issue in which people think that there is a cost and therefore aren't coming in. So I'm just trying to put my finger on why, when it's going wrong on that journey that ends at A&E, having to have the teeth pulled, why isn't there an early intervention in terms of, you know, children going in to see their dentist when it's just aching or earlier on along the symptom process? You may not know.
I certainly can give my opinion, which is that that the children with the disease, the children with all the tooth decay, come from the backgrounds least likely to have a history of regular visits to the dentist. So it's what you call an inverse care law. So the children with the highest risk of getting tooth decay come from families and backgrounds where they have the lowest rates of utilization of services at the point at which prevention and early intervention can be affected. So the pattern tends to be that the children with the highest rates of decay present late, usually in pain. And when you present as a child in pain at 4 and 5 years old, then even doing simple fillings is often not possible. And you're fairly close at that point to having to refer for general anaesthesia. So I think across London there have been campaigns throughout the whole of my practicing life to encourage families to take their children to the dentist from the age when their first tooth appears at the age of 6 months. But if you look at the figures for utilisation of general dental services at 2 years old, I think 7% of 2-year-olds.
Yeah. Sorry, Chair. My opinion, and take it for what it is, I may be completely wrong. I think a lot of parents still think you have to pay, because when we were discussing it, there's a little bit of, in the public, I think, a little bit of ambiguity as to which part of dental treatment you have to pay for, which part is free. And I think specifically within lower socioeconomic families, there may be some ambiguity as to you still have to pay even for your kids. Though you don't, it's a perception issue. So obviously your educated sort of explanation as to where that comes from has far more prevalence. But there may also be a perception issue in which people still think if my kid's got an issue, I've got to pay and therefore put it off.
Yeah, that may be true. What I would say is that the message that goes out in all our, the making every contact count is that dental care for children is free, and that you should take your child to the dentist as soon as they start to get teeth. And that is the message that is consistently applied throughout all the oral health promotion programs. But one of the advantages of running community preventive programs is that you then, because you have to get consent for those programs, you then can send information to parents saying, we're running this scheme in your nursery and school, and by the way, please remember to register your child at a local dentist. Dental care is free. Take them there now. Take your other children. It's often on the back of the community preventive programs that you get that improved attendance.
Can I add?
All right, Councillor Dennis.
I just wanted to add something in this, because dental health is a multi-component. It's just not that they don't know, or lack of awareness of either they can see a dentist or free. So if there is no preventive community-based oral health promotion programs, then there is a lack of knowledge between parents and other stakeholders. So it's a multi-component, so it needs a team approach, including school nursing and health visitors. So what we are doing in other borough, we're working very closely with health visitors with 9-month and 12-month and 18-month check. So all these mandated checks, they check either they have registered with the dentist or not, and have they been given fluoride toothpaste pack or not, so which actually decrease under 5 decay. So in Hillingdon, there is no history of preventive commission program in community. That's why the rate for 3-year-old decay is high. And the second reason I can come back to that why it's higher in Hillingdon, because the community turnover is very high here, and the ethnic minority and different people from different background, oral health is not a norm. It's not in their diary that they should raise it. It comes really low in a priority. So if you see the local population in Brexley and Bromley, it's different. So local health need assessment would be different. So our tailored program will be different for Hillingdon and different for Brexley. So we can't fit one size everywhere. So whatever we will be doing in Bromley will be different with what we will need in Hillingdon. The local need for population is different here. So because it's a multi-component, it needs team approach, it needs all other, making every contact count. Under 5, whoever get in touch with these children should be trained, should have inability to provide either packs or supervision or brushing messages, key messages. So which is lacking. We cannot see in the history of Hillingdon any of these commission programs. I think there is one fluoride varnish program back in 2015, I think Shika can add, which was for 10 schools, which was only from NHS England for 1 year. And we are working with those schools just to convey the message further, and that's it. So the lack of preventive program is the result of coming up 5-year-old with 10 extraction needed and full mouth clearance, and under 2-year-old are not registered. So what Andrew quoted, just 7% of 2-year-old in this current year is registered journally, and which is very low. So in 5-year-old is 25% registered with dentist, but 2-year-old is 7%, which is very worrying. So there is a lack of communication and messaging conveying towards the community. I would say that. Sorry for more time. Thanks.
All right, Councillor Dennis.
Yes, actually, I've got 2 questions around commissioning, which actually might relate to what you've just talked about as well. Assume I know nothing, because that's possibly true. How does commissioning of dental services work in Hillingdon? But that's my first question. I've got a second question after that. No more than 5 minutes, but
Or 2.
I think it's an important question, so I'd say 5 probably.
So the responsibility for commissioning dental services lies with NHS England, and that's unusual because most health services are commissioned by CCGs, so hospital services, GP services. But dental was, I think probably not appropriately, was separated out and was commissioned directly by NHS England. So that's services. There was a time when oral health promotion and public health were, and it was quite recently, was part of the NHS service commissioning of NHS services. But the responsibility for commissioning and therefore funding public health services, including all types of health promotion, passed to local authorities in 2012, which is not great timing when we think of the poor funding settlement for local authorities. So this is not a blame game at all. It's just very unfortunate. So the commissioning of dental services in London were commissioned by NHS England, so they've got a London office, and they commission all the local practices in Hillingdon. They'll commission the community dental services across London, and they'll also commission the hospital dental services other than maxillofacial services.
A follow-up question is, we've obviously discussed maybe where there's some gaps and maybe where there's some good ideas for trying to plug those gaps. How is that fed to the commissioners? Because I think you've obviously got opinions and working on the ground. That's good that you've got opinions. I mean, are you able to sort of basically give your views about what could make the situation better in Hillingdon to the commissioners, and do they listen?
Yes, we are, and we've only had responsibility for working in Hillingdon since April, so it is early days, but I think we've had some good meetings with our colleagues in public health and also in the CCG, and support. Those conversations are supported by Public Health England and NHS England. So there is a partnership group working, and I think the fruits of that already beginning to bear fruit, which is that we are hopeful of establishing a supervised toothbrushing scheme in a limited number of schools and early years settings reasonably soon, I think.
Yeah.
All right, Alison, you indicated.
Hi, I'm Alison Fraser. I'm Head of Children's Services at CNWL until June. Oh, right. We, obviously, CNWL have the dental services, and I just wanted to invite Claire to join me on this part because I'm just a little bit concerned that you felt before June there had been no health promotion here, and I'm sure Claire will give me more information. But in terms of health visiting, we promote oral health at all the checks we have with children at weaning, 6 months, 8 months, 1 year, and 2 years and 3 years. The problem with, not a problem, but an issue in Hillingdon is we have improved on that chart. We've come up 2 points on the chart, so we will just, I think, from a few years ago. So there has been progress, but we do a lot of work with children. It's a very transient population, so you get those children right, they move out, and then we get a new cohort in. So you're always having to keep on and on plugging this message. And also in school nursing, we do a lot of health promotion. We talk to mums about next time you go to the dentist, take the baby regardless of age. Just sit them on your lap. There's a lot of promotion, and I know Claire, who does the children's centres, will update too on what we've actually been doing in Hillingdon.
Good evening, everyone. I'm Claire Fry, and despite what my title says, I'm actually Head of Child and Family Development in Provider Services, so I'm not a Commissioner from that perspective. I've been responsible for the Council's network of 16 children's centres for the last 4 years, and within the programme of children's centres, we have a well-established Brush for Life programme, as well as a Bottle to Cup programme. So we know that in terms of supporting children's oral health, regular toothbrushing twice a day for up to 2 minutes when the children's teeth first appear is really important. And so as part of that programme, all of the children's centre staff are trained in early oral health. They've been trained by the community dental health practitioners. Each children's centre has a Brush for Life champion who has annual updates and cascades that to the teams. And so we run a range of community-based activities and learning opportunities for parents to help them understand about the importance of toothbrushing as soon as children's teeth appear, and also in order to try and engage them with their local dentist practice. We have tooth pack gifting that we talked about, so I've just got some examples. We've got 2 different types of toothbrush and toothpaste packs that are gifted. So when a children's centre is running a promotional activity, either at a stay and play session or out in the community, where appropriate we would gift the most appropriate toothbrush pack. So 1 pack is for children under 3 and 1 pack is for children over 3. And it varies according to the fluoride per part within the toothpaste itself as to which is most appropriate. So it's about trying to also physically show parents the type of toothpaste ideally they would be buying and what an appropriate toothbrush looks like too. So that's all part of it. And the packs we use have some very basic information that they have as well to take with them. So the toothbrush and toothpaste packs have historically been funded by Hillingdon's public health team. Sheikah's team have funded those to date. We are at the point where we're looking at how we will continue to provide the packs, but up to now, though, that's where they've been funded from. And we also have what we call the bottle to cup promotion as well. So that's also about within 6 to 12 months, as much as possible, encouraging parents to reduce the use of bottles and move over to cups. So, and we also would gift a free flow beaker or a doily cup which doesn't have a lid. So again, supporting parents to understand that actually the prolonged use of bottles is actually not good for children's oral health. It also sometimes encourages parents not to necessarily brush children's teeth before they go to bed, because sometimes parents might put their children to bed with a bottle, and we know that even if the bottle contains milk has natural sugars in it, which is not good for children's teeth. So that's all part of the promotion that we do within the children's centres. It's true that we don't reach every family within Hillingdon by any means. The Children's Centre programme reaches a percentage of families in Hillingdon, but the remainder of families ideally would be seen by their health visitor. And although the toothbrush and toothpaste packs aren't gifted by health visiting, the promotional aspect of the work does take place. So I appreciate it's not a supervised toothbrushing programme, it's also not fluoride polishing, but we do have the community-based prevention work that's currently ongoing within children's centres.
So why don't we have a supervised toothbrush programme and fluoride programme?
I mean, I first of all, I would like to build a little bit of context. When I joined in 2009, I joined Hillingdon Council. The rates of dental decay were in 50 to 55%. And the situation has improved in line with Northwest London. And if, I think in Claire Robertson's presentation from Public Health England, she's presented a graph. I think you have a copy of that presentation. And that graph shows that all of Northwest London boroughs are poor. So child dental health is poor in all the Northwest London boroughs, including Brent, Ealing, Harrow, Hillingdon, and other Northwest, Westminster. So that's the context. So it is probably something to do with our population. perhaps to do with NHS dentistry. Following the APOC review in 2015, we did some work on fluoride varnish with schools, about 10 schools, and we selected schools on the basis of the highest deprivation in Hillingdon. And also we carried out some promotional work in the Chimes and in Pavilion shopping centres to raise parents' awareness about NHS dentistry. We also worked with NHS England to provide 2 new dental practices, and these are NHS dental practices in Hillingdon. So Hayfield didn't have any NHS dental practice before, and there was one established, I think, in 2016 in Hayfield, and another one recently in Useley. So we are trying to ensure that we have good provision of dental health, NHS dental health in Hillingdon. We're also encouraging parents. We've also provided fluoride varnish in schools. So we are taking steps, and there has been some improvement. By all means, we do acknowledge that we need to do more, simply because oral health is an important indicator for the overall child well-being and social care, health and social care services. So I also want to say that you know, there has been reports, and if Sally was here, Sally is the oral health promotion person, I think, working with Whittington Health now. So she has had reports from parents that when parents take their children to dentists, they are told that there are no NHS appointments available, and that is not true, because NHS England does commission NHS dentistry for children, and we are keeping a record of those dentists, and I think Sally reported back to NHS England. What we try to do as public health is to encourage NHS England to use monies from unused dental appointments. So when dentists don't use the dental appointments for NHS, they return the money back to NHS England to use that funding for to improve dental health for children in Hillingdon. And recently they have agreed to fund a supervised toothbrushing program in Hillingdon. So we will be doing supervised toothbrushing in Hillingdon.
All right, I've got Councillor Harangi and then Councillor Radia, please.
I'm probably going to ask the same question I did at the beginning, which is I think it's important to understand why it's so bad, because I think unless you understand what's causing the problem, it's hard to go about fixing it. You can compare to the boroughs that are doing quite well, but until you understand what, and again, I guess it's just, you know, is there a way to find out, or what do other areas or other boroughs do? And my second question was, I know you said that some of that preventative stuff had been done for 10 of the schools with social deprivation. Was it a success, and could it then be done with some, you know, with other schools?
So just to answer the second question first, we had a health promotion team which conducted that fluoride varnish program. That team doesn't exist anymore, so I don't know what happened to that program. It was successful in the sense that the take-up was good, but in terms of monitoring where it went, we don't have records. I'm sorry. But in terms of what causes it, we don't know. I've had discussions with the dental health consultant in London, and it's not just Hillingdon, it's the other northwest London boroughs as well, which are red, and red means bad compared to to national average. There are several theories. It's strongly linked to deprivation, but Hillingdon isn't the most deprived borough. However, the deprived children in deprived areas, they do have poorer dental health at disproportionate rates, right, within Hillingdon. Also, we can always improve the breastfeeding rates, because that's another thing which has an impact on dental health. And as Claire highlighted, reduce bottle feeding and encourage breast to cup, and instead of bottle, use a cup as soon as possible. So those are the things we are trying to promote through 0 to 19 service, which Hillingdon Clare commissions.
Before I call on Councillor Radia, who was supposed to monitor who was supposed to do the monitoring of that previous project? You said that you didn't know what the outcome was, and there were some improvements, but who was supposed to be monitoring it?
I think the team transferred to leisure and well-being team. There was, yes, but I think, yeah, there were changes within the team, and
that wasn't
scope changed. Yeah.
And that wasn't followed up just because they moved.
Yeah.
Okay. Councillor Radia.
Thank you, Chairman. We all understand that the current pressures on the NHS and all aspects of health are enormous. We all understand that. But the figures that we've seen tonight are shocking, and I think, I'm definitely, I don't think any of us were expecting the figures for Hillingdon to be quite as bad as they are. I think for especially some of the demographic features of this borough and some of the things that you've touched on, we do need to be looking at upstream measures, more preventative measures to stop it getting to the final stage of very, very severe decay. I think my main point is that it seems to me that both of you from the Trust have a very clear idea of the nature of the problem and what works from a preventative perspective in terms of what you've seen in your evidence. But you're both, the Council and the Trust, you're both painting very, very different pictures of what is essentially the same scenario. And from where we're sitting, it doesn't appear that there's enough communication between you both, because ultimately these are kids. We've got, oral health is important. And I think perhaps, Chairman, if we could try and think about encouraging the Council and the Trust to perhaps continue a dialogue after this meeting and, try and put your heads together. I know, we all know budgets are limited and resources are limited, but perhaps try and think about what can be done on a pragmatic basis to try and improve the oral health of our children.
Dr. Patel first.
Good evening, everyone. I'm Lalit Patel. I'm the chair of Hillingdon LDC. I've just taken over the chairmanship in April. Can I give you a perspective as regards to a dental practitioner as to why this is happening? Okay, as a dental practitioner, I've got a 6 surgery practice in north of Hillingdon, and we have an NHS contract. In 2006, the government introduced a new contract which allocated a certain budget to each practice for which you had to achieve the targets. If you don't achieve the targets, as the lady mentioned, your funds will be taken away. Those funds were ring-fenced, which were removed 3 years ago, I think. So if you don't achieve the targets and the funds are taken away, they are not invested back into dentistry. They could go to anything else in the health sector. Now, the problem we are having here is that there are practices out there who have, and we have 30 practices in Hillingdon which are providing NHS services. And these are multi-practices as well. So it's not true that NHS dentists, there's no NHS dentists available for children. And a lot of the ladies here who are doing the CYP project are doing a marvelous job here, but funding is not available. I mean, £1.08 is it for one of those packs? And yet they cut the funding down last year for us. Is that right? And now I think they're trying to get some more funding to provide that. We are also monitored on fluoride application. So part of our contract is that they see how much fluoride application we do on children, how much prevention we do in children. And this is monitored by NHS England. So we are doing all we can at the primary level, but the awareness is not there. And Hillingdon's got a big problem where, as Alison mentioned, the population is moving. And despite providing all this information and trying to encourage children to go to the dentist, it's really, the message is not getting through. That's our problem.
Are we able to, you need to turn off the microphone. Are any of us, any of you, able to, in your figures and your research, to drill down as to where the specific problems are with regard to populations, with regard to communities, that sort of thing, so that you're able better to target the people that you need to get to? Because you say, you've all said that there's a moving population, and I'm not sure that we are, as councillors, terribly aware of a particularly large shift or churn of population every now and again. We know that there may be some very specific small groups that might change from time to time, but not in terms of, one isn't aware of a sort of exodus every now and again from Hillingdon to other places, so I don't understand that. And I just wonder whether or not there's, because CNWL had the contract for quite some time before Whittington came along, so presumably there's been a build-up of this problem for quite some time. So has work been done in the early stages of that build-up as to what's been going on? And you, again, Dr. Patel talks about awareness, which I find astonishing in one sense, because the promotion of oral health at a relatively early stage in schools and so forth that we're aware of as members ought to be getting through, but clearly it isn't. So what's happened? Anybody?
Can I just answer one of those points, which is how do you identify the children who might be most at risk? We do carry out national surveys of 5-year-olds every 2 or 3 years, and I think this last survey, which is the most recent survey, we sometimes are able to look at ward level data and school level data about the level of need, but there is a very clear proxy in many of our programs, for example, in our other boroughs, which is that we targeted those schools which had the highest proportion of children on free school meals, because that accorded with actually some of the data on the incidence of tooth decay. So it's a rough guide. If you're going to target, then obviously you want to target to the schools where you believe those children are most at risk of tooth decay.
So it would be helpful for it'll be helpful for us, I think, if you have ward breakdown figures or assessments, for us to see that, if you're able to send that to us, because it's not good enough, is it, to say we're as bad as other people. We're as bad as other boroughs in the area. It's no good saying, well, the whole of North West London's pretty awful and we're just as awful as they are. That's not good enough. For Hillingdon, we need to see what's really going on and to see what we can do, because I can't believe it can be that difficult to get a message across that ought to be straightforward and easy. So I'm thinking that perhaps we may need to have this subject as a specialist review for a working group to look at. We're pretty good at that sort of thing, and to really properly drill down into this, to do a report for Cabinet, because we could do this all night, frankly. It's come as quite a shock to us, I think, what's being said, and I think we need to look at this in a lot more detail. All right. Councillor Nelson.
Sorry, Chair. Just quickly, can I add into that, because the program that was that has been commissioned by Public Health with 10 schools. You said that program no longer exists. So there's other schools in the borough that it can be rolled out. Is there any way that we can know what's happening with that? Because you said it's going into other public areas. Why is it not being rolled out to the schools that's available? And what was the outcome of it? So I think it would be welcome if we can have that information too as well.
All right, thank you. I think we've got the Smile London presentation. So we'll. Oh, sorry. I'm so sorry. Yes, of course, Councillor Vernon.
One of the things that has come across is the lack of awareness, which I think Dr. Patel touched on. What can the local authority do to help? What are the steps that the local authority can take? And I'd like to link that into what Sheikha Sharma talked about, the program that was run, which was successful. If it was successful, why wasn't that practice carried on for other schools?
Sorry, I just wanted to say that I'm not a dental commissioner, but as a public health specialist, I would like to say that yes, it would be beneficial if we can carry on with some of these preventative programs, because oral health is an important indicator for children of good health, and it's entirely preventable. Oral disease is entirely preventable, and oral health impacts on several areas of a child's life. So yes, prevention is low cost. It's proven to be effective, and it's common sense. Yes.
Councillor Arnold.
Thank you, Chairman. I don't know who's best to answer this, but I just wanted to ask a question around capacity. Do we have enough capacity in Hillingdon? And if so, what are the sort of lead times to access it? Are there long waiting times?
Capacity in what particular area?
In dental, whether they're dental practices, or are there enough dental practices within Hillingdon to cope with the population, and how easy are they to access, long wait times, that sort of thing?
I'm not sure I can comment on that. Maybe Lalit.
Sorry, can I come in? There are enough practices in Hillingdon to look after children and NHS dentistry. It's been commissioned by NHS England. The problem is that there are practices out there, and I think Councillor Milani just mentioned early on that you go to a dentist and you think it's all private, but it's not. Children's teeth are, until the age of 18, is free. So when you say capacity depends on what funding is available to your practice. So you've got an allocated number of unit of dental activity that you have to achieve. Now, it starts from April, ends in March. Now, there could come a time by, say, December or January that you've reached your limit and you can't provide NHS services anymore because you haven't got the funding. So there is an added problem where people do achieve their targets early because they're providing NHS dentistry for other means. And yet, between, say, December and March, you might not have capacity to see any patients on the NHS. So it's really a varied program. It's since the new contract came in, things have changed. But I think somebody just mentioned how can Hillingdon help? Well, in my opinion, and the CRP is doing a good job here, but in my opinion, if there's awareness as regards to NHS dentistry is available in Hillingdon, and we have got a list of NHS dentists that are providing NHS services, and it's free for children until the age of 18, that will have some impact. Thank you.
Yes, I just wanted to say that we are using digital applications as well to help parents of young children, And now there is a mother and baby app in Hillingdon for new parents. And there is a module or a page on dentistry on there. And we are trying to ensure that there is more awareness raising through digital means as well, because some of the young parents, they have smartphones and they use them extensively, and maybe that's the way forward.
Sorry, Chairman, I think what that's fine, that's excellent, but I think they should know where to go to get NHS services. That's important, and if they have a list that of the practices that are providing NHS services, then I think there's half your battle.
I think that's what was being done, but I will ensure that that's put in place. Yeah.
I think you can get the list of practices from the Federation of Dental Committee, or I can provide you the list if you want as to who's providing NHS dental services in Hillingdon, and that north as well as south of the borough.
We've just done a review about GP and primary care services, and one of the big things that came out of that was, again, communication about a lot of different issues that would relieve GPs, because people go to GPs not just for health things, but for lots of related things, which they don't really want in the best possible way. And one of the things that we've looked at is a sort of information hub run from the council or in conjunction with citizens' advice and people like that. And this is exactly the sort of thing that ought to go into that information hub, so that if people are using that sort of information, that they get directed at a very early stage, and it's really pushed very hard. Turkey, you wanted to come in.
Thank you. Maybe Dr. Patel and Health Watch could meet. We're going to meet anyway regarding the report, and also with our council officers there, because there is quite a bit that we can do at Health Watch in terms of promoting this, because of the nature of the work we do. You know, on an annual basis we get around 3,000 visitors just to the shop, as well as access on our websites and so on. So if we have the information, we can actually help to promote some of this. So perhaps the meeting that we're going to arrange, we can pick this up, and also maybe we can meet up here as well to look at that.
Councillor
Sorry, Chair, this might be more a question towards you or more experienced members insofar as, so we've spoken a lot about awareness, which is great, and obviously that work being done, you guys meeting separately, is really, really good. But it sounded to me like a key area was getting the two high impact bits commissioned. I've forgotten what it is already, but it sounded good and interesting. So, I mean, because for me, I mean, we spoke about the diversity of the community, but we're no more diverse than Lewisham, Lambeth or Islington is, for example. And talking about people, like you're saying about mass exodus, I'm not sure we're any more transient than Southwark is, for example. So there's something there that's happening, and it probably is this piece. So how can we nudge, is it NHS England, to see if this can get commissioned? Is there any way that we can do that, or the authority more broadly can do that? Because I feel like that is probably the most significant step, is to get those pieces of work commissioned so you can get on and do it, and I don't have to do any work. That would be great.
Well, we're only sort of skirting the surface in a sense, but we need to get a much better idea about the whole structure. I mean, we're well au fait with our CCG and commissioning as far as medical issues are concerned, and we see that all the time. I'm still not very well sighted on how commissioning works for dental services. It may be that it's NHS England, it may be local, it may be a whole combination of different people. And as with everything else in health, it probably could be very complicated. But we need, if you could all get together and let us and some sort of information about what dental commissioning looks like, because what we need to be able to do is to I cannot emphasise this. It is not good enough to say we're as bad as everybody else. We're not interested in that. What we're interested in is improving what's in Hillingdon. And just saying, well, the whole of North West London is hopeless. Well, maybe, but that's not good enough. So we need to get a much better idea of where the problems are, very specifically, maybe by ward, maybe by identified areas, geographical, communal, whatever it is, because clearly there's something going very badly wrong. I just, as I say, I find it astonishing that it's a relatively simple message that I would have thought was being pushed and promulgated from a very early stage. And I don't get it at all, I'm afraid. So we need a joint effort. There was one thing very specific about Whittington in relation to Redford. We've had a number of requests from carers about what's happening there, in particular about the fact that it was all said that it was going to happen in June, but still people are having difficulties and finding difficulties. Is there any update about whether Redford's working? Is it up and running? It's a problem because it's on the first floor or something for people with access. What's happening?
Yes, the only issue of concern at the moment is the facility is up and running. It's the fact that it's on a first floor, and so there is a lift under construction. It got delayed, and although when we put in, we would advise patients that we can reschedule them elsewhere. It's obviously, we're very sorry about the fact that we couldn't open the lift at the same time as opening the facility. But I'm reliably informed, and taking into account what builders tell you, I wouldn't swear on this, but they've said lift will be in place by November the 14th. So the following week.
Okay. Specifically, it's asked, are things fully operational? When can users, carers of people who need to use the services be informed of regular dental checks so that children know, or at least the carers know, that their children are going to get regular dental checks? Okay. There seems to be some sort of breakdown in communication here, because we've had a number of, when people knew we were doing this, we've had a number of requests from carers who go to Redford about what's happening.
Okay. So all patients who are currently being seen were written to probably at least twice. First of all, to explain the change of provider, and then secondly, the new facility in Redford Way, which opened on the 17th of June. So as far as I'm aware, that the only group of patients who are currently disadvantaged and have been since June are those who need a lift to access the service. And as I said, we've made interim arrangements to provide them with care, but that lift to provide that access at Redford Way will be in place after the 14th of November. Otherwise, the service is fully accessible, and referrals to it is a referral-only service, so referrals by local dentists come through a central office, and they'll be appointed in line with the referral criteria. So I'm presuming that the issues that have been raised have been around disabled access in relation to the lift.
And does that apply to emergency requirements as well? That it's operational for those or not?
Yes. Yeah. Well, our remit is to see patients on referral, and it's open Monday to Friday, 9 to 5. So the facility. Yes, it does. It takes emergencies of its own patients. We're not a high street practice. We're a specialist service. So for the patients under our care, yes, we provide them with emergency care, but we're not a walk-in access centre.
Dr. Patel.
Can I come in on emergencies? Emergencies, there's a separate funding and separate group who provides emergency services in London. So after working hours, if you have a dental problem, you ring 111 and they'll triage you to a practice which is providing the emergency services. During working hours, it's the dentist who the patient is registered with, that's their responsibility to look after that patient.
Okay, let's go on to the Smile London presentation if nobody's got any other questions for the moment.
Chair, can I raise one issue about older people's oral health? we know through anecdotal evidence that because people are living longer and they are keeping their teeth for longer than they did 20 years ago when everybody had dentures by age 50 or 60. What has been reported to us, and that's through my discussion with Claire Robertson, who's the dental public health consultant with Public Health England, is that the teeth that older people are retaining are generally of poor quality. And if you can imagine, if someone has dementia, then there are further complications because in order to assess the dental pain and then organize treatment for a patient with dementia is quite complex. We are not fully aware about the situation with care homes and to what level staff is trained. And I had raised that issue separately with Nikki to put on this agenda, and perhaps that's an issue for which I think Whittington or perhaps Dr. Patel might have some answers on what's happening with old people's oral health.
Well, I'm a training practice, and we have trainees which are trained by London Deanery. They're trying to involve trainee dentists into getting into dementia-friendly cafes. So what they do is that the trainee dentist goes into a group which is meeting once a week or whatever. It's part of the learning structure, and they provide, as she mentioned, they provide information on how to look after their teeth when they're elderly and they have dementia, and they give leaflets explaining how to look after the teeth to the carers. That's one aspect of how we're dealing with dementia. And but as the population is getting older and older, we are having a different kind of battle to fight, treating elderly people with root decay, a lot of other problems. Yes.
So what's happening with care homes then? I mean, is there a separate commissioning that goes on with that, or?
I'm not aware of any separate commissionings for care homes.
The commissioning of the dental service, so in other words, if a resident of a care home needed to have dental treatment, and if they're able to access and accept care in a local general dental practice, then they go to that practice. But certainly the older people in nursing homes who are the most vulnerable, with the most comorbidities and disabilities, are not often able to access services in practice. They come and see the community dental service. So that's providing treatment. The separate issue that the CQC highlighted was the fact that the daily oral care of the care home residents was poor. And certainly all the surveys we've carried out in care homes around quality of life issues for the residents shows that on a daily basis they're not having their teeth brushed where they can't brush them themselves, that they are not having their oral health needs assessed. So again, in some of our boroughs, we are commissioned by the local authority to provide public health services training of care home staff, to have daily records of brushing, to make sure, and these are linked to CQC outcomes, so that home meets its CQC responsibility. We train the staff, we provide them with all the resource packs they need to make sure that on a daily basis the oral hygiene and care needs of that population are taken care of. So I think, again, there's a separate issue there. If it's a treatment service, it's just dental services and the normal pathways. But if it's around it as a public health issue, again, it's a local authority issue, which is why the CQC directed some of their comments at local authorities.
Okay, that may be another topic that we need to pick up. All right. So let's have a look at this Smile London presentation then.
So this presentation was sent by Dr. Claire Robertson, who's consultant in dental public health, and I saw it today, but I'll do my best to present the statistics within this presentation. Child oral health in London as we can see, around a quarter of children have their teeth affected with tooth decay in London, and for Hillingdon, that figure is 32.5% children, so we are higher than London's average. You can see the map of northwest London and Hillingdon on left. In fact, it's the map of London where northwest London and some of the northern boroughs look particularly poor. Again, I would like to say it's not an excuse, but it's a fact which has stuck with us for several years, and we, along with northwest London boroughs and some of the other boroughs, we have poor child dental health, and that is also a cause, the top cause for hospital admissions, especially for children aged 5 to 9 years old. The hospital admission rate for dental extractions in Hillingdon is also very high. It's in fact the second highest in northwest London. So we had 548 admissions for surgical removal or simple extraction of teeth. And this is comparing Northwest London sector, STP, with other parts of London, North Central, Southwest London, so on and so forth. And Northwest London had the highest finished consultant episodes for surgical removal or simple extraction of teeth in children, 3,033. This graph shows the proportion of 5-year-olds in Northwest London boroughs with experience of tooth decay. Not only 32.4% of children, 5-year-old, have some form of tooth decay, but also the extent of tooth decay is quite high. So within Northwest London, children with decay have 3 to 4 affected teeth, ranging from 4.8 in Harrow to 3.1 in Westminster. And you can also see the averages for Northwest London and London on the right-hand side of the graph. Okay. So this chart shows the uptake of NHS dental appointments for Northwest London resident patients, and for Hillingdon, as you can see, only 65.4% child patients attended an NHS appointment, and for children aged 0 to 5, that was even lower, 37.9% children within a year. Smile London is a multi-strand program that targets children aged 0 to 5 years, involving health, education, social care, and this is a program which Public Health England is leading on, and it encompasses aspects of looking at data and looking at where the areas of high need are, and training frontline staff on dental health, and also including increased availability of fluoride varnish, incorporating the oral health agenda within Healthy Schools and Healthy Early Years programs, and also signposting children and young families to dental services. So these are further details about Smile London program. Claire is leading on it. I just want to, the only thing I want to say, I won't go through further slides, but I just want to say that this program is now being led in Northwest London by Northwest London STP. and Claire is one of the people involved, and she's brought us all together. I think you raised the point about we should be talking to each other, which is very important. As part of the North West London SCP program, we have had a couple of meetings, and that's how we are proceeding to now implement the supervised brushing program in Hillingdon. So we are a part of this program. So these are the return on investment. This is just proving the return of investment for Smile London program. I wish Claire was here. I only saw these slides an hour ago. But this is to show the effectiveness of the program. Yeah, I'll finish there, unless there are any questions.
I suppose the main thing really is to know what the effectiveness of this programme is in regard to all the schools in Hillingdon. In particular, obviously, the infant and junior schools. I mean, have they had all of this promotional material? Are there sort of champions who make sure that the schools get this material and that the message gets across?
I don't think the program has been implemented yet, not in Hillingdon, certainly. Has it? So what stage is it?
You mean supervised
Smile London program?
No, it's not implemented yet. It's just...
I think as part of STP,
there is no practical commencement yet. It's just all on paper at the moment, yeah.
So is there a timetable for this SMILE programme to be implemented in Hillingdon?
Hillingdon is...
Yeah, I just want to say that I don't have the answer for that. I'm sorry. Neither NHS England nor Public Health England are here to answer that question, because we are not locally leading on it. It is Public Health England's programme. But they are implementing it through the STP in across North West London boroughs.
Okay, so is this new then?
Yes.
Right, okay.
Yeah.
But it can't be new that schools are that young aged schools are being encouraged to promote oral health amongst their children, can it?
No, certainly not. I think in some areas they are doing supervised toothbrushing, as I think Andrew showed a chart on different boroughs commissioning initiatives on supervised toothbrushing and other programs.
I mean, the simple thing is that, as with a lot of things, if children do stuff at school, they very often take it home. So if even if the approach of their parents, again, which one finds astonishing, but even if the approach of the parents is not great in terms of encouraging oral health, at least if the kids come home and say, well, look, I've got this toothbrush and I've been shown how to brush my teeth at school, every time I eat I should do it, or whatever the recommendation is, and it could be embedded in that way, because the kids are usually better at leading it than the parents are. But can you find out from NHS England and the STPs what the programme is for implementation in the schools in Hillingdon and in the right schools in Hillingdon for us, and come back to Nikki on it, because we need to know that it's being done pretty quick, and if the funding's there for it to be done, it ought to be done. Is it Whittington that's sort of got the contract, or not? No,
nobody have any contract yet, and nobody have any contract yet. It's just the planning at the moment, and Hillingdon is in the list. Harrow and Hillingdon is in the list in the light of this data that this is the most poor deprived borough in London.
So who'll be responsible for implementation?
Public Health England is coming up with the plan, and then they will be commissioned through either NHS England or local authority. So we are unaware of the plan yet. So I think it's best place Claire Robertson will be able to answer this question.
Right. Okay. All right. Well, look, thank you very much, everybody. I know this is going to be something that we'll want to take up further and more and in more detail. We had a whole rack of questions, but in fact we've sort of asked our own, as it were. What we've discovered so far has been incredibly interesting, but rather worrying and alarming, really. We do need to get a better grip on this and to understand it much more. So we will be inviting you all back, whether it's to the full committee or to one of our subcommittees. I'm not sure, but we'll talk about that later. But for now, thank you very much indeed. Thank you. All right, we'll move on to item 5, or move back, as it were, to item 5, the Mount Vernon Cancer Centre. Glad to see you got through your problems. Trying to get anywhere in northwest London at this time of night is an absolute disaster. So I'm glad you're here.
Thank you. I am terribly sorry I'm late. I thought I had time to do the school run and get here, but clearly that wasn't the case today. Thank you for having me back. Really the purpose of coming back is to update you on where we've got to with the Mount Vernon Cancer Centre review following the time that I was here earlier in the summer, which was just after we'd launched the review in the first place. So we've made available to you a few documents. So there's a paper that I wrote which just basically sets out the context and where we are. The Independent Clinical Advisory Group's report and the patient engagement report, which I think we were waiting, Nikki, weren't we, for the last minute to send because we hadn't quite received it. So it is hot off the press. It hasn't gone to our programme board yet, and as such it's a draft unpublished document acknowledging this is a public meeting. So we felt it was very important to be transparent and open, and we will be sharing it with all of the people that took part in the activity as well. So I was just going to sort of take you through what we've done and what the key things that have come out of each report were. I think when I came in June, July time, we'd optimistically suggested we might have some options by now, and I think I caveated that with it would be probably the fastest review in NHS history if we did, but we were determined to do some motoring. We don't have options at the moment, but there is a reason for that, and that reason has come out of the review itself. So I'll talk you through that. One of the first things that we did was commission an independent clinical review, and that involved a group of people from specialist cancer centres outside of the area that had no vested interest in what they found, that had national, international reputations. And they were accompanied by members of Healthwatch Hillingdon as well as Healthwatch Hertfordshire. We received the report back in July, and I know that we had a conversation offline about what that report said, and we subsequently published that on our website and sent it to all sorts of people so that they can see that, and again to be open and transparent. And for anyone who reads the papers, it was featured in last week's Guardian. Yes. Yeah. So the Health Service Journal had looked at it the week before and not run it. So anyway, the review suggested that we needed to prioritise or to split our work up into two work streams. One of them was looking at the short-term actions that we needed to take, and the other was about the long-term configuration options. And in that second phase, they recommended a sort of two-phased approach. The first being to identify a specialist cancer provider to take on the management of the service, and the second one to develop the options. So at that point, we carried on doing the patient engagement and asking patients what they thought in terms of option development and what their priorities would be. But we didn't do any further work on developing those options themselves whilst we identified the tertiary provider, entered into that process and identified the short-term actions that were required. So that's why we haven't got options today. So in terms of the engagement that we've done, the report is quite comprehensive. It's a long report, so I'm not sure if I don't think it was circulated with the papers in the big pack, but I know that you've got access to it. We did a number of events in different parts of the area that the centre covers, and as you can appreciate, we have patients all the way from Bedfordshire, North East Hertfordshire, as well as areas of North London. So we held a number of different events. We did some structured interviews and a patient survey, and the results are in sort of a big document that's pink. It was run independently. I attended all but one event that I couldn't because of a family matter, but they were facilitated and the report collated completely independently of any NHS organisation. The report itself pulls out a lot of the concerns that patients have raised, as well as some of the suggestions. So, for example, they were quite keen that whatever solution that we found, we looked at development of technology to see what more we could be doing with that. They were really insistent that the options that were developed were deliverable. They had initially some difficulty understanding the need for co-location. That was one of the factors that the clinical team said was very important. Once it was explained, and it did take quite a bit of explaining, and that's something we need to think about, they did understand what the issues were. But there were some sensible challenges around why can't we develop a full district general hospital on the Mount Vernon site and bring all the services that aren't there now onto the site. There were some concerns about the impact of staff if any of the site moved, any of the services moved. There was some questions really around what will happen to the companion services. So, as you're aware, there are 3 services on the site that are separate to the Mount Vernon Cancer Centre, that are not in the scope of this review but have a relationship with the centre. Those are the Linda Jackson Centre, the Paul Strickland Scanner Centre, and the Michael Sibel Hospice. To greater or lesser extents, they will have a relationship with the hospital itself. Some of them, so for example, the hospice doesn't necessarily need to be on a hospital site, whereas the Scanner Centre clearly does. I think there was some concern that whatever options we developed, we needed to be really clear what the impact would be on those companion services, as they called them. There was some concern that if there was a 2-site option, so keeping some services at Mount Vernon or moving some services, whether that would fragment the service, but it was generally a more favourable solution than moving everything. And they welcomed the clinical panel's suggestion that we needed to change the leadership of the service. So there's a lot more detail in there. But if I just move on to the clinical review, because I think it sort of sets the overall context. There was, I don't know if you've had much chance to look at it, so I don't want to go through it in too much detail if you have, but I think it sets out quite clearly the need, why we need to be looking at this service and why we need to do something. As you know, been at least 30 years people have been talking about needing to do something around the services there, and every review that's been done has never resulted in action. I think there is a different mood this time, and I think there is some certainty that this will result in some action, and none of us want to be sat there waving this report in 10 years' time saying it didn't happen. But I think some of the key things to consider around the co-location. So the report pulled out 3 main things, really. One of them was the services really need to be run by a specialist cancer provider. It suggested a London one because of its location. The nearest one outside of London is Cambridge, which would be difficult for them to manage, and given that East and North Herts, are nearer, but still quite a long way from the physical location. I think the feeling was that it needed to be London one, and there are a small number of London trusts that could do that. it suggested that, it said that acute co-location was necessary for inpatient services as a minimum, and anything that relied on inpatient services, and that we needed to have a networked model of care. So at the moment there are a lot of hospitals that refer to Mount Vernon, but the care pathway is very fragmented, and there's a lot of communication issues, technology trouble, and I think that what comes out through this is that actually there needs to be a proper network in place that works well for patients. So the provider one is probably fairly self-explanatory. A specialist provider would have access to the latest research, would be able to pull on recruitment of leading consultants, leading nurses, would have access to greater research trials and more experience in running those services. That is something that the current provider, Eastern North Hearts, has fully accepted and is working with us on. The acute location was perhaps the one that the public found, the patients found a little bit harder to understand. A couple of the key reasons that come out through the report for this include treatments such as immunotherapies, which are a very fast-growing area of cancer treatment. NICE are expected to approve 40 new drugs this year because immunotherapies have increased levels of toxicity, and the new ones coming on are perhaps more toxic than others, and that sounds very, very scary, but the potential for better outcomes for patients is really high. And if those drugs, those treatments are delivered by people who understand the toxicities and have the access to the support services that are required, those patients can have access to a greater range of treatments than they can at the moment. If at the moment you went to one of the big specialist cancer hospitals, you would have access to a wider range of immunotherapy treatment than you can at Mount Vernon. And that's simply because the risk associated with delivering those treatments on a site that doesn't have ITU and doesn't have H2U facilities is too high. And also that affects staff recruitment, because of course staff want to work with the latest drugs and the latest treatments and so on. One of the other challenges is that cancer is generally a disease of older people, not exclusively, but numbers-wise, very much so. And we are treating more and more older people, and more people with comorbidities, so with a number of different illnesses at the same time, and those other illnesses still need to be treated while they're having their cancer treatment. And what we're finding increasingly with inpatients is that they come in for their cancer treatment, but they cannot have their other treatment because there aren't the facilities or the skills. So if you have a cardiac condition at the same time, there aren't necessarily the skills around and the other departments to draw on to know whether your condition is getting worse as you're having your cancer treatment as an inpatient. Inpatients is a really small proportion of the number of patients that go through Mount Vernon. There are 22 inpatient beds, so we're not talking about a large number, but nonetheless it is a significant challenge that the hospital faces. So in terms of the short-term actions, these included things like making changes to the admission policy for inpatients, changes to ward rounds. Those have been done. Another recommendation was that we would increase the staffing for the acute oncology service, and we have approved a business case. When I say approved, it needs to go through a formal committee, but it's been approved in principle. We are constantly reviewing inpatient provision and admission policies, and I think that's where our biggest short-term concern is. And whilst we are looking at developing options and going through a process to decide what the future of the hospital is, and in the report it suggests two models. When I say models, it's not quite the same as options. They're two potential ways that care could be organised. One of those is to build a brand new cancer centre on an acute hospital site, and the option development will start to look at where that would need to be, although the report does say it should be as close to the existing site as possible. It also, the other option would be to move inpatients and anything associated with it to an acute hospital site, and to keep what we call an ambulatory care centre at the Mount Vernon site, and that would mean that any of the cancer services provided that are sort of walk-in, walk-out services, so chemotherapy, radiotherapy, that kind of thing, would continue to be provided at Mount Vernon. There would need to obviously be some capital investment. Where we get to then with those two models, both of those two models, it was suggested that there should be an additional radiotherapy satellite clinic introduced in the north of Hertfordshire. Now, that doesn't affect Hillingdon, perhaps, but that would probably alleviate some of the pressure on the current service. Some of those facilities are quite old, but that's a big part of the catchment, that they have to travel a long, long way for radiotherapy treatment, and it's been a known gap for a long time, and I think any option needs to address that. So in the short term, there is an action plan that East and North Herts are delivering in terms of maintaining the service. What I do want to say is the staff are working very hard, and all of the engagement we've done, the clinical review, the patient engagement, the staff, the quality of care that people feel they've received, the attitude of the staff to the patients, you couldn't fault. They've been roundly praised. The CQC visited the site at the end of July. They haven't published their report yet. We haven't seen their report, but there was no immediate concerns raised at the end of that visit, which was really encouraging. However, as I think you've probably gathered, we do have concerns about the inpatient side of things, and whilst we start a process, well, we're in a process to identify the tertiary provider and then to develop the long-term options, we aren't convinced that we can leave the inpatient issue to the development of options and the consultation on different options and so on. And we may need to make a temporary change, which would probably be simply increasing capacity in neighbouring hospitals to enable patients that are more complex to be directly admitted to those hospitals first, rather than what's happening at the moment, which is they're admitted into Mount Vernon and then they're transferred partway through when their condition deteriorates and the staff can't manage them any further. So we're just beginning to have those discussions at the moment because of the sustainability of the inpatient pathway. That's probably, being frank, that's probably the biggest concern we have at the moment. But in terms of the timescales, the only other thing I think I wanted to flag, I think in the report we talked about a lot of work going on in October. I think that will realistically spill into November. And then, at one point we wanted to be introducing some things in April. I've been very clear with the team, with my public engagement hat on, that I think the changes that are being proposed will require public consultation, certainly the long-term changes, and we need to be mindful of elections and PERDA and things like that. And I think whilst it says April in the report for some longer term changes to start to be implemented, that is not realistic. We do intend to go through the right processes. And I think it says public consultation 2020, and that's because we can't leave it any longer than that. There will need to be a public consultation on some options next year. It's not going to be sooner than that. I think I said last time the earliest it would be was December. It's definitely not going to be any earlier than that. It'll be sometime next year, hopefully early, with the caveat around we can't obviously launch consultation just before we enter a election period. So. That's all a little bit up in the air every now and again. So happy to take any questions. One final thing, as I spoke to the authors of the review, told them that I was coming to talk about the review, and they did say if you do have any questions, even though they're up Manchester way, they would be happy to come and talk at a future meeting. Or dial into a teleconference, video conference or anything if you wanted to hear their thoughts and where they were coming from. And that might be useful when we get to the option development stage.
Yeah. Thank you. Councillor Riley.
Thank you. It's difficult. This is, whichever way you slice the cake, this is going to be a big change, represent a big change for our residents here in Hillingdon. And we received so many papers in relation to this agenda item, And I can ascertain that 13% of the patients that are currently presenting at MVCC are from Hillingdon. But what I can't seem to identify is where the people of Hillingdon are going for their cancer treatment. So the 13% could represent 5% of Hillingdon, or it could represent 50% of Hillingdon. And I think understanding where the residents of Hillingdon go for their cancer treatment would help us better understand the nature of the change and how it will impact our people. I understand that people from the residents who fall under the ENH catchment are having to travel very long distances to come to Mount Vernon for their cancer treatment. And I also understand your point about the co-location for the inpatient unit. And, you talked extensively about when complications arise and the need to have the other services available. But I don't want our residents to be at any sort of disadvantage, and I just think from the outset I would like to put on record my personal preference for the ambulatory model, and I think you call it the ambulatory hub and spoke model, with the outpatient services being retained at Mount Vernon Cancer Centre. It's my strong preference. I know that many reviews have been carried out, you've said yourself in your reports, over the last 30 years, but that the barriers that have always been faced time and time again are related to funding. And I would be really grateful if you could reassure us that this time round the funding will actually be available. So whichever recommendations the panel find, there is actually the funding to see it through. And I'm also interested to know if any tertiary providers in London have indicated their preference to oversee the clinical. I think you want a tertiary provider to oversee the clinical leadership in the transition. Has anybody expressed any interest? Thank you.
Okay, so I'll take those two questions that you asked in reverse order, and I've noted your preference as well. Yes is the answer with regards to London. We are having conversations with London providers, with 3 London providers, because it's a procurement process. I'm not going to name them publicly at the moment. We're not at the end of that process, but there is interest. So be reassured on that front. In terms of the funding, I don't have an answer to present, but what I can say is that we have been, I don't know whether it's a change in the political climate or what, but we have been pleasantly surprised when we've tried to have dialogue on funding that the barriers don't appear to be as strong as they were even when we started this review. That was probably one of our biggest concerns, that any solution requires a capital investment, even if it was to move the service somewhere else. That's not, rebuild on the same site and bring acute services in might be the most expensive option capital-wise, and also probably in terms of footfall it might not be doable. But in terms of access to funding to build things, we're finding doors open. That doesn't mean that answers are given, but people are having conversations that we weren't necessarily expecting. So at this stage I can't give you complete assurances, but what I can say is we are feeling quite positive, that perhaps more so than in any other review in the 30-odd years. I think 1976 was the first time I found reference to somebody wanting to review Mount Vernon services. But more so, I think there's a degree of confidence around it. I think on the sort of different options around building, the other things that we are looking at are, we are obviously aware that Hillingdon Hospitals is going through a strategic review of its site, and we are in discussions with them about what their solution might be and whether that offers us a potential, as well as what other local organisations are doing, because we don't want to develop a plan in isolation when there might be a better solution if we do it jointly. Equally, we don't want to be held up by absolutely nailing our colours to the mast of another plan that's going to take an extra 20 years to deliver. So we're treading that tightrope quite carefully, I think, at the moment.
Councillor Dennis. Oh, yeah. Councillor Radia asked where are Hillingdon patients currently going for their treatment. Sorry? Councillor Radia asked as well, where are Hillingdon patients going for their treatment?
So there are a number of places where Hillingdon patients might go. So they will be having some of their treatment So with the cancer treatment, some of the pathway is quite fragmented. So some of their care is at the local hospital. So some patients will have part of their treatment at Hillingdon Hospital and will be referred to Mount Vernon for the most specialist. There is patient choice, of course. So some patients will go into other centres in London. So you have UCL, University College London. You have the Royal Marsden, Imperial College. There are some big cancer hospitals around. There are, if you go further in, you've got Guy's and St Thomas's. You've got a range of options. I think it's very much personal preference. Going back to your point about understanding where Hillingdon residents go for cancer treatment, I don't have that breakdown. I have it by Mount Vernon Cancer Centre, so I know what proportion of the patients that are treated there come from Hillingdon, but I don't have the numbers in terms of where all of Hillingdon go for their cancer treatment. I can ask my colleagues in London if they've got access to that data, and I can feed that back to you.
All right, thank you. Councillor Dennis.
Thank you. Thank you for your presentation. So obviously, in a funny way, we're here to sort of look at the long-term sustainability of Mount Vernon as a sort of site for cancer treatment, and obviously one of the things that came out very well in your presentation was it seems to be in a bit of a muddle loss at the moment about how it treats people. Is it treating people in the right way, and how should it develop? Now, what sort of came into my mind, which sort of builds probably on what Councillor Riley was asking about, is while Mount Vernon is a physical site, and that might be very, very important, but strategically, what is the service that we're aiming to provide to our residents? What is that need, and how are we going to match that? Because I think the thing that I have lost sight of when I listen to the different options, which all sound good in isolation, is how does that work in a joined up system where, obviously technology is changing, people have different needs. It's how does it, Mount Vernon as a single site is actually important but not important in this, so how does it all work together?
I think that's been one of the complex questions that we've been looking at, and through the work that the independent clinicians have done, their view is that strategically we need to be looking at the research agenda. We need to be looking at what is the future of cancer treatment, and that the big growing area is immunotherapies, and that causes a problem for the way the service is provided at the moment at Mount Vernon. The same thing with the increase in the older generation and the increase in sort of cancer prevalence in older people. And the comorbidities, that people are living longer and are living with more illnesses and more long-term illnesses, chronic illnesses that need care, and it goes. And that's what comes through in terms of their rationale around acute services, recognising the sort of, I suppose, the small sort of political and emotional impact of moving a site which is really popular, and the service. I can't underestimate how much the staff were praised, and there is a huge degree of familiarity and fondness for the Mount Vernon Cancer Centre, for that brand it's created, and that might be because patients don't quite understand all of the challenges and the things that are being mitigated on the surface. But it is very, very popular, and somebody mentioned access for North Hertfordshire patients. This review has never been about access, and one of the things that comes through in the survey is that patients are willing to travel for good quality cancer care, and whilst we don't want to pull away a service and move it miles and miles away just to create a better service, we want to create a better service for the population that it currently serves, and to do that with as little change or little impact as possible. So hence trying to look for as local a solution as possible, or a solution that might keep some services at Mount Vernon. I think it's realistic to think about, or it's realistic to be to draw the conclusion that we wouldn't be able to build a new hospital with every service in, because there simply wouldn't be the critical mass that you'd need for an A&E for a critical care, unless it was part of a wider Hillingdon solution, and we don't know what that would be at the moment.
I mean, I think just to make a very quick point, and I'll shut up, but it is a great asset, it's a great jewel, and I would hope that it could be used. I mean, what I'm sort of asking about, I don't want you to answer this question because you sort of answered the question in a way that I think the answer I'm looking for in the future is, how do we use this asset and jewel in a way which links with the strategy for the whole area, and that for me is the thing that is missing. And I think if you don't get that right, Mount Vernon will be stuck in this middle zone of not really doing things as well as it could, because it's not fitted into the overall strategy of what is needed and what is available with technology. So I mean, that's not just an observation, because I think it's a question not for now, but it's a question I'd hope that can be answered well over time, after the consultation process has happened.
I think that what's interesting, and it comes out of the report and also our discussions earlier, in a sense that Mount Vernon Cancer Unit has kind of been left to become whatever it's become. And it's not really been clear for quite some time what it's supposed to be and how it fits with everything else, given where things are now in cancer treatments. People might like it, which they do. I understand that not a huge number of Hillingdon residents use it, but other people do. I may be wrong about that, but I understood that the number of Hillingdon residents who go there or get referred there is relatively low compared to the overall numbers of people who use it. And you're right, that of course something that's nice and works well and people like it is great, but at the same time, if it's not connected to other things behind it, and in particular to the sorts of expertise that you would expect in other places where there was what we've got at Mount Vernon, you would expect something else behind that, or supporting it, or available to it, but it doesn't have that. So it's a bit disjointed and a bit left out. So really, I suppose the first thing that we'd be interested in, and again, it's not maybe something you can answer, although that's what the whole report's really about, is what's it for? What's it really there for in the great scheme of everything? And I think that's a complication. The other thing is, and it's a very blunt situation, if you go to a great deal of cost and organisational length to sort out what it's supposed to be and put that in place, and we have and I'll say the words, we have the idea of at some stage of a new hospital for Hillingdon. How does that fit in? And while we don't want to keep everything on hold forever until we get one, at the same time, planning has to take that into account, or NHS planning has to take that into account. I thought you might come in. Dr. Ward-Smith.
Yes, I just wanted to make a comment about this development of Hillingdon Hospital, because one of the things which is not identified is in the reports is that a lot of these patients would need to have district hospital support, particularly if they're undergoing things like immunotherapy, and that site has not been identified. Looking at Hillingdon, there is a large piece of land which is available potentially for development. Brunel University wants to create a medical school and it's already training paramedics, so there would be a huge input from the university, from its medical school and from the hospital if the main site was in Hillingdon. That wouldn't stop people going to Mount Vernon for radiotherapy, for example, because that is a treatment which is A, effective, and B, rarely has long-term or short-term complications. But we must have a suitable immunotherapy unit that could be built at Hillingdon if the hospital was redeveloped. Because one of the problems is that if these patients have to go, for example, into central London to protect their health overall, they will need to go by specialised transport. They won't be able to use public transport. and that is a problem. I think it was brought up by one of the patients at one of the patient engagement meetings. But it's just an idea, but it's probably not politically acceptable in the present climate.
I mean, it does depend on what... there's been all sorts of different announcements. Whether any of them are reliable or not, I don't know. But it very much depends on what any new Hillingdon hospital looks like, in terms of where it is, in terms of what it does, in terms of everything about it. As I say, I think the job of the review is very complicated, because you could spend a lot of money working out how to use Mount Vernon better at this stage to find that in some way it was compromised down the line. But down the line could be 20 years. And we don't know. And we still don't know. Now, this has been talked about for as long as I can remember. But it seems to be moving up the agenda a bit. Now, there were announcements about various spends on hospitals. There were various announcements on new hospitals up and down the country. I don't know where we sit at the moment as far as that's concerned. But, well, I'm not sure we do. But I'm not sure that should be allowed to interfere with what the report does, because I don't think it otherwise nothing would ever get done, I guess. However, Councillor Riley is right that it would be good as soon as we can to know which direction we're going in. I don't know whether Dr. Vaughan Smith had any preferences or preferred options from your perspective.
Sorry, that would be my preferred option, is to build at Hillingdon Hospital. But that probably, in terms of timescales, is not feasible.
In terms of the report and what's being looked at as far as the cancer centre is concerned, what do you think is the better option there?
Well, what I read from the report is it could include Hillingdon Hospital, because the DGH is not identified at the moment in the report.
Okay, thank you. All right. Any other comments?
Just picking up on some of the comments that you've made, I suppose it was just to assure you that those conversations are going on. So that Uxbridge proposal, for example, isn't a surprise to me. I don't feel it would be right to discuss all of those different conversations going on. I don't think I know about all of them, but when we get to developing the options, obviously we will do. I think the other thing that I think would assure you is just really thinking back to the programme board. You know, there are about 40 different members of that programme board, including the STP, including Hillingdon CCG, including Hillingdon Hospitals. We are working very closely with the health economy in London, in Hertfordshire, even in Bedfordshire and so on. So we are very cognisant of the other plans, the other developments that are going on. There's developments at West Herts, Hillingdon, all of the different announcements that are being made. You can absolutely guarantee we are following up to see what it might mean for cancer services in the area. Our priority is to create a service that has the best possible outcomes for patients. How we do that, we don't know yet, but you can be assured that we are exploring every opportunity that comes our way. And as I said earlier on the funding, we're finding doors that are much more open than we expected to.
Turkey.
Just one point really, and that's to do with the staff, because I was on the review, and the dedication of the staff is brilliant, and the skills of the staff been well recognised. My worry is that while we're waiting for all this development, in this current climate of shortage in the health service, we could lose some of that staff, and I just wonder whether there are some sort of interim measures in place to try and maintain the commitment of our staff to Mount Vernon, so that we don't lose them. I know it's a difficult ask, but
yeah, it is obviously it's a concern. We are doing a lot of work with the staff. I think the biggest thing we can do is get to decisions as quickly as we can do. One of the biggest things that we need to do is identify that tertiary provider, somebody that can actually provide that support and development of the staff. There are some staff in particular and I'm not going to name names, but there are staff that I could identify as being absolute Trojans at the moment, and you know, I can't underestimate how hard they're working, and you know, the commitment of staff at Mount Vernon. The reason they stay is because of the patients and because of the patient care, and they understand what the impact will be if they leave. So I think we are trying to support the staff as a group. There's more we can do. We are aware of that. We are having regular conversations with some of the senior team there at Mount Vernon about how they can be better supported. We commission the service, so we have a lead nurse who goes on to the service every week regularly to see how it's going and to talk to the staff. So from a commissioner's perspective, just to make them feel that they're supported. And we are talking with the provider around how they can support the staff. The staff there have been through a lot. I mean, it's not hard to run the service now, but they haven't run it for a huge number of years. It's bounced around a little bit, and I think the staff have borne the brunt of that. And we need to be sure that anything interim that we end up doing with inpatients aside, that the long-term option is a long-term option, and that the staff can be assured that any sort of transfer to a new provider, that a new building, whatever it ends up looking like, that's a home for life almost. I think we're very mindful of that. I think identifying a provider that can work with staff and making some decisions quickly is what's going to have the best impact on staff.
All right, thank you very much. Councillor Martin.
Thanks, Chairman. You probably can't answer this, but at what point do you think we'll be out of doing reviews, out of analysis, and actually have an area, sort of a period of stability? Because often in these meetings we sit and nothing's happening, but something's about to happen, and it may be in 2 weeks, it may be in 2 months, it may be in 6 months, and it's probably slightly unfair to get you to give an exact answer, but in your guesstimate, are we talking a year, 2 years, 5 years, 10 years, 30 years? Will we still be alive?
So my expectation, I'll call this an expectation rather than an estimate or anything, is that we will be consulting on some options that have been developed with the public, with patients, with clinicians on the long-term future of the service next year. Once that consultation period has finished and we have a decision on what that service looks like, we would be looking to mobilise as quickly as possible. Depending on what that solution is will depend on the length of time it takes. If it's a new hospital, I've been involved in some that take a very long time. I've been involved in some that are surprisingly fast. It depends on the scale of it and access to resources and so on, but we will be wanting to seize on any opportunity that we have. So I think we can, for the long-term solution, we can be thinking about decision next year. I wouldn't want to predict a month because it will all depend on when we're able to launch our consultation. In terms of the shorter term, I think we'll be looking to increase capacity in neighbouring hospitals to support some of the inpatient work very soon. And in terms of the provider, we're having those conversations now. We just need to get through a process and make an award a contract.
So January 21, do you think we'll be able to sit here and say, yeah, we have a plan, we know exactly what we're doing? I know I'm putting a date now out there, but something that's sort of over a year and a bit away.
We should have an outline business. We should have I'd have thought an outline business case for any new build. Don't hold me to that. I'm not a project manager, but yeah, I mean, we want, you know, this can't take 5-10 years. You know, we have to be making progress before then.
All right, thank you very much. Very interesting update, thank you. And I know you'll keep us informed as time goes on, and we'll keep a close eye on this. But for the moment, thank you very much indeed. Thank you. All right, everybody, we shall move on to item 7, which everybody will have read, the GP Pressures draft final report for the select panel, which you see amongst your papers. It's gone through a stack of revisions and amendments and so forth. There's one tiny one yet to be made before the report eventually goes to Cabinet, I think in November. Yeah. There is one thing I would say, and I know Councillor Lackmire will agree with me, and Councillor Angie would have agreed with me, is that the work that Liz did on the report was absolutely brilliant, and the way in which we ranged all over the place as we went through these various witness sessions, and how she kept up with all of it, I have no idea. But and then something would happen, and we'd go off on another offshoot and look at other things. But it's a really comprehensive report, and with a lot of good recommendations. There's a limited amount of reach that the local authority have in order to be able to help out with this position. The whole idea was to try and address the pressures on GPs, because as I said earlier on, the starting point was that a significant percentage of the time or their working time is taken up with not really medical issues. There are all sorts of things that make people unwell because of what's happening. And one of the biggest areas that we looked at was how do we signpost people better in order to take advantage of what in fact are an extraordinary array of services that are available, but people just don't know about them, or they don't know how to access them. It ought to be relatively straightforward. So there's a lot of work gone on as far as that's concerned. A number of the recommendations are involved around that. During the course of the actual review and during the course of the witness sessions, the panel actually solved some of the problems. One of the big problems that GPs were telling us about were issues about they were told they had to have a GP's letter in order to help them with regard to X, Y, and Z, in particular housing. And so we were able to get our housing people together with the GPs and essentially say, right, talk to each other. And they quickly discovered that, in fact, they didn't need these letters. It was just a perception, or perhaps in certain circumstances, letters were needed, but in a very, very minor number of instances that were not the number that people thought they needed. So we got that one solved, and according to the GPs, it actually had the effect of reducing their workload so they could do other things by a not inconsiderable percentage. And so what we then did was to get them in contact with other departments in relation to whom patients would come to the doctors and say, this department of the council thinks says I need a letter. Very often they didn't, or a referral, or something from the GP to put me further up the list. And again, that whole communication sector has helped them a great deal. So we kind of problem solved as we went along, which would have been in the recommendations, but you can't really have a recommendation if you've done it. So in relation to some of the things, they did get done. So any comments or views or anything, Councillor Riley? Oh, hang on. Oh, well, I'm not sure that we need to... Oh, well, maybe we do. Well, I'll come back to that. Councillor Riley.
Thank you, Chairman. I just thought it might be helpful to have a bit of a discussion around the 8th recommendation, and I'd be grateful for clarity. Does this mean that any care home of the size which incurs the CIL payment would then be referred by the planning team to the CCG to see how the CCG feels about it? Because the report talks about pressures of care homes on GPs, and the 8th recommendation suggests that planning applications for new care homes in the Borough of Hillingdon, this is my interpretation, should be referred from the planning team should consult the CCG about the possibility of building these new care homes. And I just thought it would be helpful to understand a little bit more about what this would actually mean in practice. Would it be a case where the planning team asks the CCG and the CCG say, oh God, no, our GPs are already so stretched, we can't build a new care home for 30 people. So there wasn't. It's a great report, don't get me wrong, but there wasn't enough information in the report for me to understand what the 8th recommendation would mean in practice. We have got an ageing population, and we need care homes and those are likely to be majority Hillingdon residents.
I think the point of that 8th recommendation is because it's in the very early stages in the sense of understanding the relationship between applications for care homes and the capacity for GPs to be able to deal with that, that there should be that consultation. It was a relatively new thing to have brought up and needs to be looked at. Inevitably, there's always going to be a juxtaposition between supply and demand in that sense. So the more care homes you build, the more difficult it will be for the existing GPs to take those people, if that is what happens, onto their books. Or is there a different system, a different way of looking at it? Dr. Vaughan-Smith.
As you may well know, general practice is being reorganised in Hillingdon into what are called PCNs, where groups of practices work together, and there are going to be 8 or 9 of these in Hillingdon. The Confederation, which provides services over for the whole community, is very engaged with the problem of patient care in homes, and they are beginning to provide a service which means that the GP's involvement will be reduced because the Confederation will provide medical support to people in care homes. They will still have their individual GP, but the loss of the day-to-day routine stuff will be carried out outside the practice itself. So the problems, which I'm well aware of, which we've had in the past of GP practice saying, oh God, we can't take any more elderly patients, will hopefully diminish.
Chairman, I just think that, thank you, Dr. Vaughan-Smith. I just think it would be good to clarify that if these proposals were to go ahead in practice, what the level of influence the CCG would have over planning applications.
Chairman, if I may, the SIL payments are payments that are made instead of Section 106s. So it will be for any supporting, in terms of any applications that come through, having spoken to planning, they'd be happy to actually include this in their procedures, so that if there were anything that they could actually have a SIL for, community infrastructure levy for, that would actually help in terms of the provision of GP services or support services around there, then they could do that, but to actually consult with the CCG rather than just going ahead and doing it.
Sorry, so you're saying that the consultation would not be about what the CCG's views are on whether the care home is built or not. The consultation would be about how the SIL payments should be spent. That's absolutely fine. Thank you. I'm so sorry, that wasn't in the report. I'm not going mad.
No, but at the same time, it's also a useful exercise for the consultation to take place, to see what to have a much better idea in terms of the of the provision and what there is. It was an idea that was put forward as being something relatively new, and we all thought it was a good idea, so that there was a bit more clinical input or a bit more medical input into the decision making and into the knowledge base for the decision making.
Yeah, it's funny because I read it and I got something different, so that's where maybe more detail might be helpful to be added, because the way I saw it was actually it creates dialogue between the CCG and the planners or the planning officers to prioritise workload and strategy for how it's delivered. We've got so it might just be tightening things up, might be better, because for me it was never about whether the planning permission is granted, but creating a dialogue between the different groups, so that the delivery of healthcare in that area is prioritised in the right way. And things
but the point about this,
we have gotten 3 different interpretations.
That's good, because what the point of this recommendation is to get dialogue going and to see what how that works with regard to the input of the CCG and also to see how that sits with how planning make decisions on these particular issues. Good. All right. Any other observations? Oh, Dr.
Further point, and that is the ultimate objective of changing the way that patients are treated is to improve their care, and particularly in such a way as to keep them out of hospital. So there's a benefit for lots of sectors within the NHS, and also the care of these patients will be improved.
Good. Councillor Arnold.
Thank you, Chairman. I just wanted to put on record that I think it's important that this committee thanks the select panel for conducting the review, comprising of yourself, Councillor Edwards, Councillor Vernon, Councillor Lakmana, and Councillor Prince.
Thank you very much. But as I say, as I said at the outset, that's very kind. But Liz did a fantastic job with the drafting and the note taking and all the rest of it. So yeah, it was very good. So the idea is that this goes to Cabinet in November. Everybody happy with that? Yep. Okay. Yes, it is a very good picture. Oh, you mean at the, oh right, okay. Work programme. Nikki.
Okay, so our next meeting in November will be our usual health updates. As Councillor Riley mentioned earlier on, we will be having PC Hull attending that meeting to talk about the SIM project. CNWL are the other organisation that are involved in that, and they will be here too, so it will be a bit more of a joined up approach to actually talk to members about that. I'm also going to ensure that members get an update from the CCG on Michael Sobel Hospice at that meeting. Now that the GP Pressures Select Panel has completed its review, we need to be looking at another review. And I'm wondering if, following on from the discussion that was held earlier, don't want to preempt anything, but I'm thinking possibly dentistry.
I have to say that although we had a number of very interesting questions that had been put together for us, I think it was much more interesting, well, no, not much more interesting, but it was equally interesting what we actually did. Because, speaking for myself, and I think everybody else, I was just completely surprised by what we were being told and staggered. It seems that because everywhere is bad, our badness seems to not necessarily at all be acceptable. But I'm not quite sure that the grip has been quite as strong as it should have been in terms of getting things sorted out and done. So I'm going to propose that we put together a select panel, a working group, to really drill down and get some answers and see what's going on and get some proposals for getting our position in dental and oral health better. Agreed?
Can I?
Go on.
I just wondered if you could be more specific.
Well, yeah, but I'll write to you, Nikki, about how specific we need to.
But in terms of will the select panel actually be looking at children's oral health, or will they be looking at oral health in general, or will they be looking at the older people's oral health?
To a large extent, well, we could concentrate on children first, and then do everybody else, and then do old people, but that would be three. Yeah, I think we should start with children and prevention and message distribution and all the sort of things that clearly are not being done, or if they are not being done terribly well. I don't believe that. Well, maybe I don't know, but I don't believe that it can't be so difficult to work out where the problems are and where the communal problems are, and then to target those. And I don't know if that sort of work is being done. I mean, asking the questions about the SMILE project and realising that it may not or isn't currently being implemented and we have to wait for somebody else to look at it. We just need to crack on. So I think we'll look at children's dental and oral health first.
As members are aware, there was a review already undertaken in 2015 by the Social Services POC, I think it was at the time. So that would be a useful basis from which to start, because that was on child oral health. So knowing what the state of the nation was back then, to be able to then determine how things have changed or not.
Maybe get hold of a copy of that report and send. Yeah, and email it round to all members, and then we can all have a look at it, and then we'll appoint a select panel. Yeah? Yeah. Okay. Good.
I'm done.
You're done? Anybody else got anything at all? No? Other than that, thank you very much, everybody, for coming, and we'll see everybody on another day. Thank you very much.